Um, Madam is a well-known pain physician, and no need to introduce you as we are know you are the well-known pain physician all over the world in India also. First of all, Madam is presently director at Ashirwad Institute of Pain Management and Research Center at Mumbai. Present affiliation is honorary consultant in pain medicine at KM Hospital and St. GS Medical College and National Burns Center, Airoli. Madam's major achievements are developed a new ethopathogenesis and effective treatment regimen for CRPS that reverses not only pain but also the disability of CRPS. Proposed a new concept of neuromyopathy to explain motor neuropathy, a vital component of neuropathic pain. Even Madam developed a ketamine-based protocol for burns patients. Even pain education proposed and developed the curriculum for fellowship in chronic pain medicine to MUHS Nashik. Madam got almost 100 international publications, 10 chapters in textbooks, Best Researcher Award in 2015 at International Conference on Recent Advances in Pain. So, Madam, most welcome on our ISA Nanded platform. We are conducting this case meets regularly on the behalf of our Silver Jubilee celebration year with Platinum Jubilee of National ISA. So, please, Madam, you can start now.
Okay. Thank you, Dr. Chincholkar.
Thank you, madam.
So I'm going to speak today about CRPS, which is considered as an impossible to cure condition. But what we have seen in our clinic is that it is very routinely being reversed. So the topic is impossible to possible, a cure for CRPS. So complex regional pain syndrome was first described 1.5 centuries ago during the American Civil War. And International Association for the Study of Pain named it complex regional pain syndrome. Previously, it used to go by many names. One is erythromelalgia, one is RSD, and then shoulder hand syndrome. Many other names are there. But International Association for the Study of Pain named it as complex regional pain syndrome, described the clinical diagnostic criteria for it, which was later modified by a special interest group of doctors in IASP into Budapest criteria. CRPS 1 is when there is no demonstrable nerve damage, but there is only mainly soft tissue manifestations. And it's called CRPS 2 when there is there is definite demonstrable nerve injury. So the incidence of complex regional pain syndrome is supposed to be 50,000 new cases in US alone every year. Incidence is 5.5 cases per 100,000 persons after fracture, surgery, trauma, deep bruise, or limb ischemia. Female to male ratio is about 3.4:1. So the women seem to suffer much more. It's more common between 40 to 49 years, though it is also reported in children. The most common inciting event is a fracture. So it has been 19 to 43% incidence after arthroscopy in lower limb, TKR, hand surgery, and fractures. And then upper limb fractures is 7.9 to 32% incidence. So they have said after fractures how much and after limb surgery how much. So looks like fractures have more incidence than surgery. CRPS may be mild and self-limiting and may not even get diagnosed in this process, or it can become a chronic debilitating disease which impairs activities of daily life and hampers the way of life and the quality of life. So symptoms and signs of CRPS are, there are sensory symptoms, vasomotor symptoms, pseudomotor symptoms, and motor symptoms. So what we are showing here is sensory symptoms, which includes severe pain, a burning sensation, hypersensitivity, insect crawling sensations, and shocks. Here is this patient. You can see that just a very light touch, he's struggling with that. And you can also see how he's wincing. And the scapula has been winged. Vasomotor changes. See this hand, which is so much swollen, and the temperature is 37, whereas the other hand is 35 degrees. This is vasomotor symptoms. And then this is color changes. Color change also comes in vasomotor changes. And then this is trophic changes. You can see that there is increase in the hair and also in the sweating. So 97% of patients have motor manifestations. This is quoted by a study where they studied 973 patients by Weldman et al. The motor symptom manifestations may be decreased range of movement, like this lady. You can see that she cannot lift. She has to lift it with the other hand. And then they can also have dystonia like this. Okay. There may be difficulty performing dexterous movements, stiffness and weakness, myoclonus, tremor, and dystonia. Children are less likely to have, as I mentioned before, children can also have CRPS, but they are less likely to have a noxious inciting event, and psychological issues may play a bigger role. This is a 1978 paper. Children respond better to therapy and are less likely to have long-term symptoms from CRPS.
Madam, slides are not moving.
Now, it's moving or no?
No, ma'am.
What is being
Only
seen
first
now?
slide is there.
First slide is there?
Yeah,
Okay,
yeah.
Oh, should I say stop sharing and then come back again?
Yeah, you can open in other window also. You can.
Okay. See now, now you want I'll say stop share, start sharing again. Shall I share my entire screen and see? Or a window, okay. Okay, now is this seen? I'm changing the slide. Are you able to see? Are you able to see or no? Am I audible? I seem to be not there at all.
मैम स्लाइड चेंज नहीं हो रहा है. हेलो मैम स्लाइड चेंज नहीं हो रहा है.
Change nahi ho raha hai. Okay, I'll ask somebody to help me with this. I don't understand this business. Anisha? My slides aren't moving. See, I'm sharing.
Wait, can I put this?
Is it now moving?
No, madam.
No, ma'am.
Oh, so what do I do? Stop sharing and go by rejoin?
That's strange. It should show.
Should I reopen the whole thing again then?
You can share the screen only. Yeah.
Share
Right.
entire screen? Which one should I
No,
share?
it will share your entire screen including this. So that's it.
So I just share.
Now click on this. Okay.
Yeah. Now see if it is sharing.
Yes, madam. Yes.
Now it's
Yes,
sharing.
madam. Yes, yes.
Okay.
Now
Yes,
easily,
madam.
yes, ma'am.
Okay, you
It's
can see the
working.
video now. See.
Yes, yes, yes.
This is hypersensitivity, which is being seen there. This is a young boy, 14-year-old boy with CRPS, with winged scapula, and he's not even allowing her to touch even slightly. So this is extreme hypersensitivity. This is a patient showing the vasomotor changes with temperature being 27 here, 37 here, where it is normal hand is 35. This is trophic changes with all hair growth. And then this is the color change, which you see, which is a part of vasomotor symptoms. And then 97% of patients have motor manifestations, decreased range of motion as this lady, and she's not even able to lift it. She has to lift it with the other hand. They cannot, they have difficulty in performing dexterous movements. They have stiffness, weakness, myoclonus, tremor, and dystonia. This is dystonia, dystonic movements going on. Children, as I mentioned, do get CRPS, and they have these, both the papers are slightly old papers, but they both say that they respond better to therapy. There may be psychological issues, etc. And 10 to 30% of CRPS patients may go for recurrence of CRPS. Now, this is the same boy where I was showing you, 14-year-old boy with winging of scapula. We gave a stellate ganglion block. See, this is an ultrasound image of a stellate ganglion. This is the trachea, this is the thyroid, carotid, IJV, and this is the longus colli muscle. And here is where the injection has been given. So stellate ganglion block was ineffective in this fellow. 1 week later, we started our treatment of dry needling. And within 3 sessions, he became like this. You had seen the winging of the scapula here. I'll show it again. See, this winged scapula has become normal here. And then his hand grip increased, and he is now developing something like 8 to 10 pounds per square inch pressure. And you can also see movements are normal, full range of movements. This is another girl, 16-year-old girl. 16-year-old girl also, though a teenager, is considered as a pediatric case when it comes to CRPS. You can see after a metatarsal fracture, she had CRPS. And this was the maximum movement. When I tell her to dorsiflex her ankle, you can see only the toes are dorsiflexing, but not the ankle. And because of this, her walking was very much abnormal. You can see that all the toes are dorsiflexed, and she's basically doing only heel walking. She's unable to walk normally. And after our treatment, 1 week of continuous sciatic catheter and dry needling, you can see how normally this girl is walking now. And she's also able to dorsiflex. This was fixed in this position, but here you can see how well her ankle is moving. So what are the current treatments available for CRPS? One is medications like neuromodulators, painkillers, etc. Then ketamine infusion has emerged as a treatment by itself. But original ketamine transfusion was the anesthetic dose where they made the patient admit the patient and push her into a coma-like situation. But nowadays they use low-dose ketamine infusions. The first dose managed, the first coma-like situation dose managed to reverse the CRPS fully. But the low-dose ketamine infusions only give temporary relief of pain, maybe for about 2 months, 3 months, etc. So, and what they do is they keep repeating these infusions. One of the physiotherapy has been one of the mainstays of CRPS treatment, in that is the only thing which has worked in CRPS with any credibility. But it has a ceiling. Not everybody responds. And those who respond also, it will be something like a yo-yo situation sometimes. They get better, they get worse, they get better, they get worse, kind of thing. Sympathetic blocks, stellate ganglion block or lumbar sympathetic blocks, are another modality which has been very useful. Then in many patients, they may have what is called as sympathetically independent pain, in whom the sympathetic ganglion does not work at all. So in those patients, there is no treatment at all available. So people do spinal cord stimulation. So today, in the West, most of the most reliable treatment for CRPS is spinal cord stimulation. However, though it is more reliable than the other things, the sympathetic blockade, as I was mentioning, sympathetic blockade is the mainstay of interventional treatment, lumbar sympathetic block. But after all the data which has been available, there is insufficient evidence to support or refute the use of sympathetic blockade. This is O'Connell et al. In 2016. Then spinal cord stimulation, I was mentioning to you. Spinal cord stimulation can be useful after the patient has failed conservative measures. A prospective randomized control study comparing spinal cord stimulator with physiotherapy found 50% of the patients experienced more than 50% improvement in pain. This is a study in 2000. Similar results were demonstrated at 2 years, but the benefit disappeared by 5 years. So spinal cord stimulation is something which works initially, but seems to fail thereafter. And in addition, none of these treatments will claim functional improvement. All of them have pain relief and that too 50% improvement in pain. They are all very specific in that functionality does not improve. They don't even advise that the patient should expect functional improvement. So outcome specific review of CRPS, this is one study. This is whatever this unpronounceable name in 2016. They perceived pain relief and pain score improvement, quality of life and satisfaction with spinal cord stimulator were rated as 1B+, means it is not really significant in this RCT. Evidence for functional status improvement and psychological effects is inconclusive. And sleep hygiene, and when I say sleep hygiene, it means how easily they can go back to sleep and have a dense sleep. Resolution of CRPS are non-existent with all these treatments. Non-existent evidence or too low quality and evidence level zero. And analgesic sparing effect seen in non-RCTs. This RCTs did not show any analgesic sparing effect, which means they continue to take the opioids which they were originally taking. So evidence is 2C+. So in this background, I started my CRPS work somewhere in 2004 and 5. At that time, treatments included stellate ganglion block. I started continuous brachial plexus block along with stellate ganglion block. My logic was, just doing a sympathetic block, which stops working after 2-3 months, may not really help in getting rid of the spinal sensitization. So I thought, let me do continuous brachial plexus block. At that time, I had just come out of anesthesia and my expertise was in regional anesthesia. So I went towards continuous brachial plexus block. And I put an indwelling catheter and tunneled it subcutaneously and connected it to an infusion pump. So with this continuous infusion, this is the fluoro-guided stellate ganglion block, and this is a stimulating catheter which is going into the infraclavicular brachial plexus. And this catheter, as it has gone here, is tunneled away like this. From here, it is tunneled to this place. And then it is connected to a pump which is carried by the patient like this. And this is filled. You can see that this is a pump, elastomeric pump, which is continuously infusing at 2 ml per hour. So this produced very good results. So I did this in about 6 patients. All were happy with pain relief at rest. They started sleeping well. Physiotherapy became less difficult for them. But movements were still very much restricted as well as painful. The pseudomotor and vasomotor changes, that is the swelling, the warmth, etc. of the hand, they would keep on recurring. They would become better, but after that, whenever they tried physiotherapy, these symptoms would come back. So, but in general, the patients were comfortable. So I just continued with it. And after 2-3 months of continuous infusion, all of you know how difficult it is to maintain a continuous catheter for 1 month, 1.5 months even. And to avoid infections, etc., is a very big problem in these patients. But anyway, in these 6 patients, I managed to keep the catheter for about 45 days or whatever. And this allowed quite an aggressive physiotherapy. Even though it was painful, patients would cooperate and do it, because I would give them a bolus dose, which helped in providing some amount of pain relief for physiotherapy. And by doing that, you can see a patient who was like this, swollen, stiff hand, which could not flex like this, later became. So this is the problem with CRPS patients. I have given a continuous brachial plexus block, but with that also they are unable to flex their hands. So I knew that there was something very definite problem with the muscles in these patients. But with continuous aggressive physiotherapy, you can see that a hand which was like this has become normal. And then he also could flex his hand. So like this, I reversed about 6 patients like this, but it was very slow recovery over 2-3 months. Then came my 7th patient in 2005. He came, and he came like this. This is the CRPS hand. He's completely unable to do anything with this hand. This is the normal hand. I'll play that again. Normal hand flexes, this hand cannot flex. So I kept a catheter for about something like 6 weeks. He failed to recover, and his hand was like this. At the end of 6 weeks, he's not able to hold. He's able to hold this. Today warrior said send him to somebody called Chaya Verma in science. So I said, okay. So since he did not improve, the surgeon said, I will operate on this, madam, and I'll release the metacarpophalangeal joint. The moment he did that surgery, CRPS came back full blast, and the patient went back to this kind of a state. So all this was very disappointing to me, where I thought, as an anesthetist, I believed in my blocks, and I couldn't understand how these patients, in spite of the block, they just don't seem to move their hand. So when at this stage, I was doing some amount of dry needling in other conditions. But since I thought that CRPS was neuroinflammation and a neurological disease, I did not think I should do needling. But then in 2006, this patient came to see me, and typical CRPS patient with lot of hyperalgesia and allodynia, severe pain, sleep disturbances. And she also had major motor symptoms. You can see the swollen hand, see the slowness of movements. This is the normal hand. This hand she is not able to lift. Classical shoulder hand syndrome. So in this patient, I did the same thing, stellate ganglion block and a continuous brachial plexus block. But 7 days after block, she still had significant painful restriction. You can see that she is in pain, and she couldn't go beyond this. And she's on a continuous catheter here. So I said, so what do we do with this? At that time, whenever I told her to lift the hand like this, she would point to her this area and this area. She said, it hurts so much here and here. I said, what muscles are here? Pectoralis major, minor, and coracobrachialis. And this is biceps insertion. So since I was doing needling, I said, okay, let me try needling in CRPS. So I did needling. I just put this number of needles, something like 7, 8 needles. These needles are in pectoralis major. This is in coracobrachialis, and these two in biceps. And to my astonishment, immediately after when the needles were taken off, you can see the lady who was at 90 degrees has gone off to full range of movement. This was astonishing. I thought this is some kind of a fluke. But I said, even if it's a fluke, I want to investigate this. Let us see what's happening. So, but within 18 days, all my other patients would take 2-3 months. But in this lady, because I kept doing needling every other day for her, within 18 days, see the kind of recovery, that kind of interest returning in jewelry. So she's got full range of movement at shoulder, at hand, and everywhere else in the hand. So this was something amazing to me. And after this, I said, let me look at dry needling for CRPS on a regular basis. The results with dry needling continue to be uniformly consistent and predictable. The sensory symptoms and pain would disappear after just 2-3 sessions of dry needling. Pseudomotor and vasomotor symptoms would take about 15 to 30 days, and motor symptoms and signs would take the longest time for recovery, about 30 to 60 days. But even this is wonderful, because when the motor symptoms are reversed, that means that the CRPS itself is reversed. So these are 2 patients where I started with them like this. After 2-3 weeks of dry needling, see this hand and this hand. And this man is writing with this hand. So all these, both the patients after 3 weeks of dry needling. So then I said, what happens with needling? Let us see. So this is a vasomotor symptom. That is, it's almost 38 degrees temperature in this hand. And this is a patient where, she had recovered from CRPS, and then she wanted to have certain better improvement because she had a claw hand, because she's a CRPS2 patient. So because she wanted relief of claw hand, she decided to have surgery against my advice. I said, don't get operated. I don't know if we can reverse the CRPS. But she was very casual. She said, you are there, you will reverse. And she went for surgery, and unfortunately, she developed CRPS again. So this is recurrent CRPS, which has happened like this. And then we have put needles in her muscles here, the flexors and others, forearm flexors. And you can see the temperature is still 37. But after needle removal, post-DN, the temperature has gone to 35 degrees. That means there is a direct evidence that needles reduce the inflammation, and that is why the vasomotor symptoms go away. So in addition, motor impairment and disability were the first to appear in all these patients, and they are the last to disappear. Here is this girl. Could not even,
and after I
squeeze
squeeze
this
like there is emerging the letters like this, then getting them there.
what she's saying is, after I flex my hands, I cannot extend. The same girl, after treatment, sorry, this is before treatment, you can see that she's not able to hold the thing. She's doing exercises. She's not able to do much. She's struggling, you can see.
The flexors are stronger.
But after needling, you can see that she is able to open the.
Where does it hurt when you do this?
Yeah, okay. Try. And she's doing fine functions.
So this was an activity which you could not do before. Very good. And mind you, this is your left hand, which is not very as skilled as the right hand.
So all these patients would recover in a very predictable way. Like this lady, sorry, here. This lady has severe dystonia. She cannot do anything with this hand because the hand is shaking like this.
And then later,
this dystonia extends into the arm also. The same lady, after 20 days, you can see that. See, there is no dystonia. She could carry a bag. She recovered completely. So our usual situation is by day 3, they come like this, day 3 of treatment. By day 5, they are able to flex a little more. And you can also see that there is wrinkling happening. By day 10, they are able to squeeze a ball. Day 12. And by day 17, she's able to hold this bulb, but she's not able to generate any pressure. She's at 0. The normal hand is able to generate about 8 pounds per square inch. But by day 22, you can see the same lady is able to generate about 4 pounds per square inch. 4 pounds per square inch pressure in the hand means she's able to do most of the activities of daily life, like opening doors, carrying weights, getting into bus, hold the handle of a bus and get into the bus. So all these activities become very easy for them. So this is yet another patient, severe dystonia. Okay. This is a very intricate movement to hold the thin cup of stem of the teacup and to lift it to the mouth in a controlled manner for a patient who was like this is not easy. So precise fine movements become possible. I was very happy with these results, but I had no clue why these results were coming. I'm sticking a few needles into the muscles. Of course, it was quite a, what shall I say, educated way of doing dry needling. I was isolating the flexor groups and the extensor groups and doing dry needling. But I was puzzled as to why exactly does this do this? If CRPS is a central neuroinflammation, why should needles stuck in the muscles help these patients? So answer came 1 year later in 2007. I was observing this patient. Okay. See this? This is severe dystonic movement. Okay. And when I watched this guy, I thought, oh my God, this is co-contraction. His hands are trembling like this because there is co-contraction of the flexors and extensors. What happens is the flexors here and the extensors here are both contracting at the same time. That is why he is neither able to flex nor to extend. And when he tries to flex, the whole hand goes into a trembling. So, and the moment I thought of co-contraction, everything became very simple to me. EMG also shows, there is one study where they have shown that agonist and antagonist show co-activation. See, in the normal patient, when flexors flex, the extensors should relax. And when extensors are contracting, the flexors should relax. This is called reciprocal inhibition. This is a part of all normal movements in all of us. But when reciprocal inhibition does not happen, sorry. So when that happens, naturally the co-contraction results. So this is the explanation. So here it is as if in CRPS patients, flexors and extensors both are held tight because they are in severe contraction and they are neither able to flex nor extend. There is an animation here which shows exactly what happens. You know, the muscles are here, but the tendons are here. The tendinous insertions, the patient pulls when she does these movements. That causes a local inflammation and that's why they get the swelling. She didn't get the swelling after our block, but she got it after exercise. So this is the reason why the pseudomotor and the vasomotor changes recur after a continuous brachial plexus block after a bout of physiotherapy. So this is the animation which shows that. So when the extensor is flexor is contracting, the extensor has to stretch like this. And here is the flexor muscle. When the extension happens, that is stretching. So this has to happen if proper movements have to take place. And then there is another googly in addition to this. When the muscles are tight, that pulls on the tenosynovial membranes of the hand. You can see how many tendons are there and how many synovial sheaths are there. So if this is the tendon, this sheath around it will get inflamed because it's a snug fitting sheath. So when the person tries to do movements, hand movements, there is friction and inflammation happening here. And that is the reason why, though the problem is in the forearm muscles which are tight, the swelling happens in the hand. If you ask a CRPS patient, he will tell you that all my pains are in this region. They will not complain of pain in the forearm. So CRPS is actually like a dequervain stenosynovitis, but it is something, dequervains involves only the thumb, whereas in CRPS, it involves all the extensor and the flexor tendons. That is the reason why CRPS patients are in such severe pain. So now how does tenosynovitis come in? I'm showing you here. See, because of the CRPS stiffness, the hand is not moving. The muscles are contracting, but he is not able to flex. You can see he's trembling. And very little movement, but the muscles are contracting with all their might. And this causes tenosynovial inflammation here. And that is the reason why you get such a severe pain and the whole hand is swollen in CRPS. So this is an animation I had made so that I could explain this. I presented this data in ASIP convention in US. So for that invited talk, I made these animations. So that is the reason why you get a hand like this in CRPS. Now, if you put ultrasound on this hand, it demonstrates that the swelling here, the edema in the hand, is not in the subcutaneous tissue. This is the skin subcutaneous tissue. Here, there is no swelling at all, no water accumulation. But around the tendons, these are the tendons, around the tendons, there is fluid accumulation here. Here it becomes even clearer. These are the extensor tendons, and you can see the effusion around those tendons. But after treatment, once we relax the muscles, if you see the same patient after 3 weeks of dry needling, you can see that the hand is no longer swollen. And if you see the tendons, these are the tendons. Sorry, these are the tendons here. And what look like this is looking like this now. So this is the normal hand. You can see that the tendons are here and there is no effusion around it. Whereas in the other hand, CRPS hand, you can see that there is a lot of tendons, effusion around the tendons. So this happens because of this very severe pain that of tenosynovitis. These patients do what is called as neglect-like syndrome. Because it is so painful when they move, they stop moving. So this is a lower limb CRPS. A 26-year-old girl had THR for severe painful rheumatoid arthritis. And she unfortunately developed CRPS. This, you can see the skin peeling off because of the neglect-like syndrome. The girl just will not move her leg. And she also had a foot drop, as a result of which she could not move. You can see that the temperature is 38, 39, and you can see the skin peeling. The same girl, after sciatic block and dry needling, you can see the same. This is the normal foot. And this is the same girl. You can see nail polish, interest in dressing and things like that. This is the leg which had CRPS. This is how it looks. Now, she also had quite severe clonus. That is because of co-contractions of dorsiflexors. Dorsiflexing the leg, immediately there is an ankle clonus happening. This is because the dorsiflexors and plantar flexors are in co-contraction, and the flexor dominance makes this clonus to happen. Thank you. So this girl, with all these problems, after, you can see that within a week she's walking. You can see the foot drop there, and she's using a walker. Initially, she came in a wheelchair, but within a week she's walking. And then the next week, she's not using a walker. She's walking by herself. The foot drop is also better. The week after that, much better. This girl went on to full recovery at the end of 1 month. This is another patient with neglect-like symptoms and severe pain. Again, foot CRPS. This fellow developed CRPS after removal of interlocking nail. And he had severe causalgia because of sciatic nerve injury during the surgery. And he had foot drop. You can see that he will not allow anybody to touch his feet because it's so painful. You can see pus oozing in between the toes, simply because it has not been cleaned. You can also see the skin peeling like this. But after treating him with continuous sciatic block and dry needling, after 45 days, you can see the guy is walking. Because of the foot drop, he had to have a splint. He still has the splint. And this guy went all the way to normalcy. Foot drop continued. We couldn't do anything about it because the nerve damage was there. He's a CRPS too. So now I knew that these problems are there in the muscles in CRPS. So I said, let me see if ultrasound can demonstrate the objective evidence of muscle pathology in CRPS. So clinically, it was obvious motor abnormality, but can we see it on MSK USG? So this is what a normal muscle looks like. The normal muscle is echolucent, means it is blackish, and with bright punctate and curvilinear echoes. All these little bright echoes, they show the perimysium that appear as bright streaks. The muscle outlines are very well defined in any normal muscle. The muscle cytoarchitecture is highly organized with repeating links of identical structural proteins. That is why it is echolucent. But in CRPS, what happens is this is replaced by, see, this is a normal muscle. This is the normal hand. You can see the outlines well. And this is a 26-year-old girl, not some old lady. But this is the way her muscles were looking in the normal hand with 18 months of CRPS. Whereas the CRPS hand looked like this. See the level of damage. I cannot see the outline of radius because this is so bright. And you can see that there is no division of the muscles like this, but it is simply a mass of whitish tissue. This is CRPS muscle. So after my treatment, after dry needling, and at this time I was still using continuous brachial plexus block, you can see that this girl cannot flex beyond this. That's, her hand is stuck at this level. So with a hand stuck like this, that means she cannot make a fist or use that hand for anything. So this is what her muscles look like. But after about a month of needling, you can see that muscles have gotten their normalcy back. You can see the outline of the muscle clearly. And you can also see in this whitish fibrotic tissue, there is echolucent muscle reappearing. And when you see a change like this, there is clinical improvement also. You can see that the hand is flexing quite well. So ultrasound is able to show me objective evidence of muscle improvement. So before this, the only investigations that are available for CRPS were the 3-phase bone scan. In CRPS, in the 3rd phase, there is increased uptake of tracer in the bone scan. First phase is dynamic phase, 2 to 3 minutes. Phase 2 is tissue phase, 3 to 5 minutes. Radio tracer uptake in the bony structures is phase 3. That happens after 2 hours. So another picture is the ultrasound. On X-ray, you will see osteoporosis. This is the normal hand, and see this, how osteoporotic these bones are. So this is an X-ray evidence which comes in late in CRPS. After the CRPS is about 1 or 2 years old, you will see a picture like this. But ultrasound will show diffuse osteopenia and juxtacortical demineralization, subchondral erosion. These are the features of CRPS. But as I showed you here, in CRPS, you see a muscle like this, that's enough to diagnose CRPS for us. And you see it when the patient comes to you the first time for assessment. So when ultrasound is used for diagnosis, muscles affected by CRPS show hyperechogenicity. The outlines are indistinct or obliterated. In severe cases, several muscles coalesce like this. You can't make out which muscle is which because outlines are all gone. They coalesce together to form one hyperechoic mass. There is a distinct reduction of muscle mass compared to the normal side. Fibrous tissue, it is the fibrous tissue which is echogenic. That is why you see hyperechogenic tissues in CRPS. So USG can be used as a diagnostic modality. So I described this, I published this paper in Pain Practice in 2013. Unfortunately, thereafter, nobody has done this study to either contradict me or corroborate my findings. So mine is the only paper going on. And see, you can also see that structural changes in muscle are seen in all patients of CRPS. We have reversed about 205 patients of CRPS so far, and all of them show this change. Even my juniors, if they look at it, they are able to diagnose, yes, this is a CRPS muscle. So in the early phases of CRPS, the changes are seen only in flexor digitorum profundus and superficialis, but later it becomes one continuous mass. Those in later phases, 3 months, and those with surgery and those with severe disability show the most marked changes. So this is the left hand, and this is the normal hand. This is the CRPS extensors. It is so obvious. If you look at it, you can say that this is CRPS. So this is again a normal hand, abnormal hand, normal hand, abnormal hand. And these changes have come. This is a 70-year-old lady, 72-year-old lady. She came to me in the first week of CRPS. Within just 7 days, you can see the changes in the CRPS muscle. So it is like immediate changes are there in the muscles which can be picked up on ultrasound. But the unfortunate thing is, even ultrasonologists don't know that these changes can happen. As I said, my paper was published in 2013, but no ultrasonologist seems to have taken any interest in this. Maybe that is because they don't get referrals for diagnosing CRPS. I don't know what it is. Anyway, that apart. So if this is the normal muscle bulk, you can see how much less muscle bulk a CRPS hand has. And the same thing in extensors. You can see that the normal hand is so bulky, but the CRPS hand is so thin because of this. You can also see it clinically as a wasted hand, but sometimes there is effusion in this hand and also muscle edema, which makes it look as if it is thicker also. So I published another study called Efficacy of Musculoskeletal Ultrasonography Due to Complex Regional Pain Syndrome in 2016 from those of how to distinguish it from neuropathic pain. How do you diagnose CRPS, whether a patient has CRPS or neuropathic pain? This is neuropathic pain because you can see clear outlines of muscles and mainly echolucent muscles, and whereas this is how CRPS muscles look like. So the CRPS, the neuropathic pain muscles look like this. This is the normal hand, which is not neuropathic. And you can see that this is more muscle. There is less muscle here. The muscles in neuropathy show reduction in size of muscle, but retain the normal architecture. Contrast this with CRPS, where complete destruction of muscle structure is there. So all this we have published in this. So this is another case where we did before and after motor function recovery. We did dry needling in these patients as the sole treatment. And these patients, before the dynamometer reading was 0, the goniometer was very much restricted. Pinch gauge had this reading. But you can see after dry needling for 1 month, the pressure has gone from 1 to 11 psi, pounds per square inch, which means this person can do everything normally. And you see this angle, which was so much reduced, is now 90 degrees at the metacarpophalangeal joint. And what was here has gone there in the pinch gauge. So these patients also showed pre-treatment, this was the muscle. Post-treatment, this is the muscle. So these changes are very obvious in all patients of CRPS. This is not a bad ultrasound, but this is the kind of image you see in CRPS muscles. But the same patient, after dry needling, this is a bilateral CRPS patient, you can see that the patient has gotten back structure after our treatment. What was so wasted like this has become this thick. And this also, this is looking like a Viran jungle, whereas here you can see clear outlines of muscles. So all these patients had only dry needling as the treatment. This is the patient with a bilateral CRPS. You can see CRPS in this hand and in this hand. But after our treatment, you can see that she's able to generate 3 pounds per square inch in the left hand, 4 pounds per square inch in right hand. With this, she's able to do all her daily activities as a housewife. So this is a paradigm change in the treatment of CRPS based on a very different understanding of pathophysiology of CRPS. When you think of CRPS as a co-contraction, it becomes easily treatable and easily reversible. And the outcomes of this treatment is improvement in pain. Pain is history after just 2-3 sessions. Motor takes about a month or so. Sensory and vasomotor and pseudomotor changes all get reversed within this 1 month. So let me talk a little about dry needling, how you do it for CRPS. See, there are many people who are doing dry needling these days. I'm happy about it. But the needling in CRPS has to be very, very specific. The use of ultrasound visualization allows us to use long needles to reach the depths of muscle while avoiding damage to pleura, nerves, vessels, and viscera. USG-DN versus conventional DN is we use about when physiotherapists are doing dry needling, they just use 25 mm to 50 mm needles versus we use 25 mm to 120 mm needles. And we usually use about 35 to 50 needles versus 6 to 10 needles used by them. And we do about 12 to 20 sessions, whereas they may do only 6 sessions. So that means we treat a lot more muscles and we use a lot more needles, and our needles are much longer and we do more sessions. And that is the reason why we are able to reverse not just CRPS, but practically every kind of neuropathic pain we can reverse, including cancer. In fact, it is in cancer we get some of our very good results. But that's a different topic altogether. This is showing ultrasound guided dry needling, where in the extensor, in the supinator, you are seeing a needle come in. This is in the flexor needles. And this is the way we put needles in these patients. These needles are in the flexor group. These are in the ulnar flexors. These are in the flexor digitorum superficialis and profundus. These are in the pronator teres. These are in the brachioradialis. This is in the biceps. These are in the thumb extensor and abductors. So this is the flexor pollicis. So all these needles, they are not haphazardly put, but in a very calculated way. This is a needle in the extensor. So this is another patient. We start the needling. 1 day of needling is done from pectoralis major right up to the hand. And even in the hand we do. And another session will be back of the neck going right across the shoulder to the hand. So these are one day we do the flexor aspect, 1 day we do the extensor aspect. We do 3 sessions of needling every week. And needling is always followed by physiotherapy, proper physiotherapy. This is something which is to strengthen the flexors. These are elastic springs which the patient keeps pulling so that she can strengthen her hand. This is something which can strengthen the hand as well as in turning. And this is a mirror box. This is climbing the stairs, which stairs means there is for the shoulder. And here is what happens is many times we have 2-3 patients at the same time. Here is this Bayani teaching other patients. This Payani is a recovered CRPS patient.
Uncle, abhi aap.
So dry needling treats the primary pathology, and physiotherapy optimizes the dry needling effect. And dry needling makes physical therapy much easier. So since needling is helping, I went through CRPS literature and myofascial trigger point literature, and our findings of what we see on ultrasound, muscle structure disruption. CRPS literature addresses the possible pathophysiological mechanisms like neurogenic inflammation, etc. They believe that there is a neurogenic inflammation in the spinal cord which somehow travels across the nerves and expresses itself as an inflammation of the hand. That is neurogenic inflammation. I believe there is nothing like neurogenic inflammation here, but it is a co-contraction of the muscle that gives a inflammation of tenosynovitis. Myofascial literature details energy crisis and inflammation in muscle, which is expressed as integrated hypothesis. We propose that co-contraction leads to selective muscle ischemia in the digital flexors and extensors, or pronators and supinators, or abductors and adductors. So their structural disruption with a consequent tenosynovitis manifests with a local inflammation rather than as a neurogenic inflammation. So this is a diagrammatic representation. If this is the nerve ending, this is the muscle, and this is the neuromuscular junction. At this place, if at the neuromuscular junction you put an electrode, it will pick up what is called as miniature end plate potentials. That's what you see like this. Whereas when the nerve is irritated, there is lot of spontaneous neural activity which leads to end plate noise. This is called end plate noise. So what happens with end plate noise is that the muscles are in a state of contraction. Sorry. Muscles are in a state of contraction here. The actin and the myosin are overlapping each other. So the muscle is contracted, and after some time, this becomes a contracture. This leads to local ischemia, acidosis, and local energy crisis. This leads to inflammatory mediators, which gives rise to rubor, dolor, calor, etc. as features of inflammation, and which, if you look at rubor, it is vasomotor symptom. If it is dolor, it is pain. And then calor is temperature, and swelling, tumor. Tumor is the pseudomotor finding in CRPS. So all this leads to nociception and pain. And this also leads to autonomic stimulation. But what I have not shown here is when you do a sympathetic ganglion block, you interrupt the cycle at this level. So the autonomic stimulation is nullified and the pain goes down. But this contracture here is not altered by the stellate ganglion block. And that is the reason why stellate ganglion block effect is temporary. Whereas dry needling comes here and addresses it and aborts all this local ischemia and inflammatory mediators, nociception, pain, autonomic stimulation. So everything is aborted by dry needling. So if you look at a muscle like this is what a normal muscle looks like. If you take one muscle fiber, this is what it looks like. This is the perimysium inside, and there is the endomysium, and portions of the epimysium project into the muscle to divide the muscle into compartments or fascicles. And this is what we see on ultrasound as bright echoes. So what happens in CRPS? This is something very interesting that you can see, a video of the CRPS muscle. Can you see this disco going on here? This is because the muscle is in a state of severe continuous contraction. This is co-contraction in action, you can see. Because the muscle is in co-contraction, you see something like this. And this is a patient with extremely severe pain in the hand. We have done needling here. After the needles, you can see that there is hardly any contraction here in any of these muscles. And you can see, this is the median nerve here. You can see the vessels here pulsating. That is because now the muscle is quiet. You can see the vessels contracting. And after DN, this is what it looks like. You can see again, vessel is artery is contracting, but there is hardly any contraction in the muscle. And what happens is, whatever relaxation that has come in this muscle is there to stay. And when the patient is seen next time, there is no contraction again. You can see it's a quiet muscle. 4 days later, the original hyperactivity of muscle has disappeared. This correlates with the patient report of reduction in pain, swelling, and warmth. So if you try to correlate the integrated hypothesis to CRPS, The constant contraction causes the initial stiffness and the ischemic damage, which causes the muscle to virtually disappear from the muscle within the endomysium and perimysium. The aggregation of fibrous connective tissue gives the USG appearance of extreme hyperechogenicity. And because the contractile hypoechoic muscle is gone, it causes weakness, while the predominance of tough connective tissue leads to the stiffness. So what happens is like this. Because of this constant contraction, that 24/7 unrelenting co-contraction leads to severe resource depletion followed by ischemic damage to muscle fibers. So that is the reason why this is a patient. If you see the date here, I have seen this patient on 10/3/2017. This patient could not get treated that day. He said, I'll come back after a week for treatment. He was from outside Mumbai. He came back on 17th. You can see that his flexion has increased. He's gone into claw hand within just 1 week. So the importance of dry needling in CRPS is that once the importance of co-contraction was understood, we found that it was the motor pathology that triggered the inflammation that gave rise to all the manifestations of CRPS. That is the pain, the sensory symptoms, the pseudomotor and the vasomotor asymmetry. Each one of these signs and symptoms respond specifically and predictably to dry needling. So I tried, there have been people who have done histopathology in CRPS. They have described myopathy. And this Vanderlaan et al., they said that there is a pathology of skeletal muscle in the complex regional pain syndrome. So muscle histology in amputated limbs. See, there are certain centers which specialize in amputating CRPS limbs, which is horrible, but it is being done. And these muscles have shown fiber atrophy and fatty infiltration and nuclear clumping. So there was a paper like this which showed that there is a selective degeneration in the A alpha fibers, which supply the muscles, and in the C fibers. The smaller A delta and fibers which carry pain and temperature were spared. The authors said that large A consequently affect the associated innervated muscles. That's exactly what I'm finding on ultrasound. This provides an explanation for the profound structural disruption that I have shown in CRPS muscles. So here is a patient with post-TKR pain, severe inflammation on FDG uptake, extremely increased FDG uptake. And in this patient, I took out a biopsy. This is showing variation with atrophic fibers. And this is an atrophic fiber, which is showing nuclear clumping. So this was from one of my patients who came to me just after 2 months after TKR. So this is an early case. And here is another patient of mine who came later, after about 1.5 years or something like that. You can see that the red stain fibers are muscles, and whereas collagen is blue stain. You can see that there is a major predominance of blue tissue in this. There is more collagen than muscle in this patient. So I won't go into all this. We can have questions on all these things. So I will not go into all this. I just wanted to show you some lower limb CRPS. This is a doctor's wife who came to me with a swollen ankle like this. And this is the way she was. Lot of difficulty in walking. But after sciatic catheter and dry needling, within just 6 days, she's like this. At 1 month, she's walking like this, climbing stairs. You're walking straight now. Okay. So very good reversals. And this is a soldier. He's a special forces person who came with gunshot injury to the spine. And I used only dry needling in this guy. And after that, he is walking with calipers. He's a paralyzed guy, completely paralyzed when he came. But you can see that he is able to walk with a walker and all after just dry needling. And this is an interview with him.
This is Major Manish Singh of Indian Army, who is Special Forces, and who came to me in 2014 with severe causalgia, inability to sit, and he had to travel in an ambulance to my clinic. And after the dry needling for about 2 months, he improved considerably. His causalgia went down, causalgic burning went down, and he had other pains which went down. And he also developed a stability in sitting, which allowed him to start his shooting, precision shooting with a pistol. Tell me, what are all the improvements that have come, and in what way has it improved your life?
First of all, the burning has gone down considerably, and at least by 40%. Because of that, I'm able to sit for longer duration. Also, my sitting posture has improved because of increased muscle strength, especially on my left side where the exit wound is there. And this situation has, in my shooting also, this thing has helped me a lot, because in shooting I cannot afford to wobble or even move even by a millimeter.
How many hours do you shoot?
At least I'm able to shoot 4 to 5 hours now.
4 to 5 hours. Can you assume the posture? What posture do you use?
It is like this.
And you carry a 1 kg pistol in your hand.
And there is no support on the left side also. I'm allowed to take support from behind, but that is mostly frictional kind of a thing. It is not supporting me from, it is not giving me any kind of a fulcrum kind of a support. So I have to take this off, and I have to take, to counter weight, I have to tilt a little left, and I have to shoot like this.
With 1 kg in your hand.
So you can imagine how difficult it must be to carry a 1 kg weight in the hand and sit for 4 hours and do this. I think this is another soldier, but let's see.
Dry needling was started on 2nd of Feb, and after 3 sessions, I got a result that my hypersensitivity has gone completely.
And you could allow the physiotherapist to?
Yes, I allowed the physiotherapist to touch my hand. Then after the swelling has gone down in my palm area.
By what days?
After 5 days.
After 5 days.
After 5 days, and this functionality in the passive movement, the active movement both has increased.
So this guy is another hero, Kashmir hero. So anyway, the outcome of CRPS has been uniformly bleak with all kinds of treatments, as you can see in all these things. But if you think differently with a paradigm shift in the understanding of pathophysiology, reversal of CRPS could be routine. It is routine in our clinic. All it takes is a thorough understanding of the anatomical and physiological aspects of dry needling, readiness to learn dry needling, assess its efficacy in CRPS objectively. In short, all it takes is a readiness to let go of the previous ideas of CRPS, which have not anyway worked for anybody, and look objectively at what I'm proposing here as a new pathophysiology. So these are my publications. If anybody interested can contact me later, and I can share these publications with you. So there are about 10 publications. Thank you very much. It's been quite a long talk, I think. Oh my God. 1.5 hours almost.
Wonderful, really wonderful talk, madam.
Okay, thank you. Yeah, any questions I am happy to take.
Madam, first of all, I will thank Dr. Varsha Suryavanshi, madam. She guided me to your number and all these things. I'm really thankful to Varsha. And first of all, whenever we see people's, so and your work is very miraculous, madam.
Yeah.
Your slides and your videos really, really very miraculous. I never seen like this, and I'm really interested now in pain management like things.
Yeah, see, the thing is, these results are miraculous. You don't see such results anywhere in the world. And we are probably getting this because we are looking at it from a very different perspective. That's all. So I think we do need to pursue this and go ahead with it. Let's find, if many people do this, we can find Indian data and produce these results.
Madam, can you please stop sharing?
I have stopped sharing, I think.
No, it's continuing. Okay, no
Okay.
problem. Okay, madam.
Yeah.
Any questions from audience?
Hello
Yeah.
there.
Yeah.
Can you hear me?
Yeah, I can hear somebody. I don't know who's speaking. Please identify
Oh, hi
yourself.
there. Yes.
Yeah.
Hi. My name is Dr. Ram Dotarkar. I'm one of the pain consultants in actually UK. But I have
Yeah.
I've been in touch with all of my friends, including Sachin and Varsha before. So thank you. Excellent. I mean, I was listening to your talk. It was really good. An amazing insight into the dry needling techniques, madam.
Yeah. Thank you.
Couple of questions. Of course, you have mentioned about the literature, and unfortunately, there is not much of a literature apart from what you have presented.
Yes.
And unfortunately, it's not one of the main practices in UK at least.
Yeah, I know.
So yeah, and but I do agree with the pathophysiological mechanisms that you just explained, and it makes a lot more sense because nothing else works for CRPS anyways. So the only ray of hope can be what we're doing here. My other question was regarding how long do you keep these needles in for when you're doing the dry needling?
Yeah. I usually keep these needles for about half an hour.
Oh, I see. Okay.
If you saw that video which I showed of the muscles going into a disco-like situation, that goes on for about 15-20 minutes. So I keep needles in for about half an hour so that all that hyperactivity is, it dies down. And then we take out. And when you take out the needles, see, if you try to redirect the needles in these patients, it's very difficult because the muscle is gripping the needle. Whereas by 30 minutes, the needle comes out like butter.
Okay.
Muscle has
Right.
relaxed.
And
So
I see.
there
Okay.
is, I couldn't cover half the things in this talk, though I spoke for such a long time. I couldn't cover most of the things really, because there is a wealth of understanding to be had in the dry needling technique and other things. Not only that, I nowadays don't use continuous break complexes at all. We just do dry needling.
Right. Great. Thank you. Thank you for your answer. And as you mentioned earlier on, you do one group of muscles at a time. So flexor one day and extensors the other day.
Yes. Yes.
Okay.
That is
Now, and in your, I mean, you have mentioned in your paper that the series of 7 patients, but I'm sure you must be continuing to do these patients at the moment. So the paper has been a while ago, but how's your experience been since then? I mean, as a routine, when you are doing this, you see the improvement within few days, you said.
Few days. See, pain relief is after 3 sessions. That is 1 week. And the vasomotor and pseudomotor changes go in about 15 to 20 days. The motor changes are the ones which take longest to go. The sensory symptoms also go away within 1 week. See, the hyperalgesia and all that, they disappear. It's something like routinely they disappear. There is no doubt about it. And it is like we have reversed about 205 patients. And all of
Oh,
them
wow.
have, we have shown this. And when I say 205, 205 is the number I have seen. It's not that I'm presenting to you 205 patients who did well. All of
Okay.
them, that's the thing.
Okay. Great. No, thank you. Thank you for your answer, and thank you for the lovely session that you have presented today.
Yeah, thank you. I think
Thank you.
Mekevar, Dr. Mekevar
Yes,
is
yes,
wanting to
yes,
ask a question.
yes.
Yes.
Please ask Sanjay.
Hello. Hello.
Yes. Yeah, I
Hello.
can
Good
hear
evening, ma'am.
you. Good
Yes, ma'am.
evening.
This is Dr. Sanjog, ma'am. I'm consultant pain physician practicing in Pune.
Okay. Yeah.
Hello.
Yeah.
Yeah.
Yeah, I
So
can hear you.
actually one question was regarding that continuous infusion through continuous placement of a continuous catheter in the brachial plexus. You said that you are not practicing it nowadays. And
Yeah.
uh, my other question is, you target uh, when you're putting the needles, you're targeting one needle for one muscle, or in one muscle you're putting 2 3 needles, proximal, distal. Uh, what is
Many more.
that is? Yeah.
See, what we do is we put at least 2 3 needles in each muscle, and many of these needles go through
Okay.
many muscles. So actually, I
Okay.
may
Okay.
land up putting something like 8 to 10 needles in one muscle. So it's quite
Okay.
complex kind of needling, which is possible because of the ultrasound, either ultrasound, or I think by now I
Yes.
seem to be carrying something like a 3D image of the muscles in my head, which I think anybody who does dry needling for a long time with ultrasound will get into that. So that's what it
Yes.
is.
Yes.
We use lot of needles.
Okay. Okay. Okay.
Yeah.
Okay. Thank you.
Yeah. Yeah.
Any questions from audience?
I think they're all tired. It was a long talk, right?
No, madam, not like tired. I will say one quote. You don't see gods in heaven. You will see around you, and like I see one goddess in front of me today, because
Okay.
you make changes in people's life. That's
Yeah.
the great
That
thing, and
is,
you are doing this.
see, what you have to understand is we are all nimittas. If God chooses to make you the nimitta for a good thing for somebody, how much more blessing can you ask for? It is like, thank you.
So I think I will conclude this session.
Okay.
So, madam, heartily and very much welcome on this platform. And again, you should come on this platform. It will be better for us and
Yeah.
to. And your session for USG dry needling sessions you are doing with newcomers, and you do routinely their workshops also. So, can
Yeah.
you tell about that, madam, please?
See, I don't do this on a regular basis. What I have seen is people express an interest, but then they disappear when it comes to registration. So only when some 5 6 people are there saying that, look, please do the workshop for us, I will do a workshop. And you can't anyway do workshop for more than 10 people because I have a small clinic. So when there are about 10 people, we can do a workshop. And in that, I will be demonstrating the ultrasound guided dry needling. And first will be the anatomy, which describes the anatomy of the muscles first. And then we go for the sono anatomy, and then the technique of dry needling. And probably the best way to learn dry needling the way we do it in the ultrasound guided kind of dry needling, it might be a good idea to do something like a 1 month fellowship in Ashirvad. That would be the best way to learn it.
Thank you, madam. Thanks a lot. You came on our ICNANET platform.
Yeah. Thank you.
So I conclude this session, madam. Thanks a lot.
Please. Okay. Thanks. If you have recorded it, share it with me.
Yeah, madam.